Okay, so today our topic, we're going to be covering the impact on practice and converting from CR to DR for mobile imaging examinations. So just a disclosure, both myself and Ryan have nothing to disclose. We have no conflict of interest with regards to this presentation. So just an overview about what we're going to be discussing today. I'm going to be covering just a very brief history about CR and DR. We're going to cover information regarding our hospitals and the sites that we individually work at, the upgrade from CR to DR, which Ryan will be covering, and the benefits. I will then be covering what we have learned, a suggested workflow when transitioning, staff feedback, and some case examples at the end. So upgrading from CR to DR is by no means a new concept. The studies have been well documented, the benefits well documented. So I'm not going to bore you with the details and cover the facts. I'm just going to go over what we know and what is a well accepted and well established knowledge about upgrading from CR to DR. So the studies quote an overall improved image quality when upgrading to digital imaging. There is an overall dose reduction for patients. We see faster examination times and overall improved patient care. So what we're going to be talking about today is whether or not we as a site were able to actually witness these benefits with our upgrade and any of the pitfalls and things that we had to overcome that we can hopefully share with you that you can gain knowledge from our trials and tribulations. So our hospitals. Lakeridge is comprised of 5 sites. There's the Oshawa, Whitby, Bowmanville, Port Perry, and our recently merged Ajax site. At the time of purchase, our Oshawa and Bowmanville sites were the busiest and thus required digital upgrades. Oshawa consists of 2 main towers, one with 9 inpatient floors and 2 major wings, including the critical care unit, and the other with 7 floors. For a non-isolated ambulatory patient, it could take an average of approximately 15 minutes to perform a mobile exam on the highest floor in the farthest wing of this hospital. Our expectation within our site is to respond to any stat mobile request within 20 minutes of order entry. So it was rare that more than one examination could be completed on the same trip away from the department, unless the patient rooms were very, very close or near adjacent. So the Oshawa site actually purchased 2 mobile units, given the busyness and the setup of our hospital.
And the Bowmanville site, it's a smaller community hospital located just east of the Oshawa site. It just comprises of 1 main building with 2 major wings on it. And those 2 wings contain our emergency department, critical care unit, 3 inpatient units, and we also have 3 ORs. Portable exams are often performed daily at in our emergency and critical care floors, and very rarely on our medical surgical inpatient unit or in our operating room. So there was, just like Oshawa, an increased amount of portable examinations, and again, going from CR to DR helped reduce our imaging times. Bowmanville staffing model, because it is a smaller site, only accounts for 1 technologist to be working at a time. So especially on the evening and night shifts, that 1 person is responsible for all CT examinations and x-rays. So when you leave the department, we found that you didn't know when new exams were ordered because you didn't always receive phone calls or notifications when you were off out of the site, out of the department and in a different location in the hospital. So the benefit of that, the new machines are they have updated work lists that can keep us informed of any new examination while we leave our departments. So when we upgraded from CR to DR, we did have a set of key users that were trained. So our charge general technologist, along with 3 X-ray technologists, were trained, and that helps us cover all of our shifts at all of our sites, so that someone's always available if there is any troubleshooting issues. They were trained directly from the vendor off-site, and then they came back and ran in services with all the staff members to make sure that we were all trained adequately to use the machine. They went through different types of troubleshooting that we can expect to see with the machine. went over daily maintenance and calibration of the detectors as well. And our key users set up all of our protocols. So they had to go in and build all the exam lists, add all the views for all the different tests that we can do. At the Oshawa site, they had a multi-cassette CR reader in the critical care area. Took up quite a big space right beside like the medication dispensing unit and some other equipment. So we were able to remove that and free up some space in the critical care unit. And we also noticed that the mobile machines that we acquired do draw quite a bit of power when they're charging. So we did have to have dedicated charging stations and electrical wired into our department to accommodate the new machines. So some of the benefits we saw with regards to workflow, we noticed that we can easily complete more than one examination before returning to the department. So like just mentioned, with that 20-minute turnaround time for a stat request, we're now able to hit that target even when we are out of the department. So we get that constant notification that there's new exams to be performed, and we're even able to see on the machine what location the patient's in as well. Our new orders, when they refresh into our work list, they do appear bold, so we're able to identify them a lot easier. So again, helping us hit that target. And patient locations can be displayed as well. So it doesn't get as specific to tell you the patient room. It does maintain some privacy, but it does tell you the ward that they're located on, so you can easily get to there. We did like that the technical factors for the equipment can be set either at the main control area or on the tube head itself. So after you're making your final adjustments, you can even adjust your technical factors right there at the tube head. So a lot of us have found that very helpful and increased our and improved our workflow and decreased our imaging time. Obtaining images is a lot easier than our older CR equipment. So the tube head has quite a range of motion, and it's able to lock into pretty much every angle and align very well to the detector. So we noticed that when we're obtaining our images, especially in trauma situations or non-ideal situations, we're able to make sure that we're always perpendicular to our detector, getting better image quality. So we're not getting grid cutoff as much anymore. We're not getting elongation and foreshortening in our imaging. Okay. Benefits for patient care and safety. So in a couple slides, we'll show you a previous image with our CR technology versus our DR. Both are CareStream, and they're both images in the ideal range. Patient identifiers are available on the unit as well. So we have full name and date of birth. And we have the ability to view the images immediately. So we find it very helpful because we're able to make sure that we've captured all the pertinent anatomy, and nurses and doctors have also really enjoyed it, especially in our critical care and emergency departments, because they can see the images right away, make any adjustments to any tubes or lines, or assess the patient's condition immediately. Okay. And Jess will go over a case where it was extremely beneficial for that as well. Repeats can be done without having to disturb our patients as much. So small adjustments can be made, and then an exposure can be taken immediately. Technical factors can be adjusted if the exposure index was non-ideal as well. And we've noticed that our technical factors we've been using about half of what we traditionally used, so our dose is reduced by at least 50%. And that was a suggestion from CareStream. They recommended that when we first start, to use our same KV for our exams and to drop our MAS by at least half. A good thing about the machines for safety are that they can only be accessed and used with username and password or by badge access. So it prevents unauthorized use of the equipment. The only staff that are able to use it are the X-ray technologists. So you don't have the chance of someone moving and damaging the equipment or someone using it inappropriately. And there's also different stopping mechanisms on the machine. So the machine weighs roughly half a ton, has a very good self-drive mechanism, but there is an auto stop built in case of collision. Okay, and here's two images of before and after. So the image on the left is with our CR technology. They were both performed on the same patient about a week apart during our transition period. And on the first image on the left, we used 117 kV with 5.6 MAS. We had an appropriate exposure index for Carestream CR within our 1600 to 1800 range. Image on the right, so that the technical factors used there were 117 kV and 2.5 MAS. You can see the image quality is much better. We have better definition of the lung markings. Same patient, same positioning, so we can assess them very well side by side. This one also had appropriate exposure index, so the limit's a little bit different for the DR machine. It's 14 to 1500, and we used less than half the dose and obtained far superior image. And these images here are for the different digital displays that we have on the equipment. So there's the main one on the right. That looks very similar to Carestream CR, and you can access all your patient information there. That's where all the full options are. So you can pick your exam, adjust your technical factors, find your patient location and work list. And on the TubeHead, there's the ability to pull up a patient work list, adjust technical factors once the exam is opened, and make small modifications to any technical settings. And the machine here, it folds into a pretty small compact form. The tower is collapsible for improved visibility. The TubeHead also docks very small as well, and you can see that it's angled in that locked position there. It can swivel in any degree in any direction. The orange bumpers along the bottom edge, those are where we have our emergency stops. So if you were to collide with anything, the machine would stop driving, and if you let go of the handle, you can see that if you let go of the main handle, the machine will stop as well.
So I'm just going to really quickly go over what we've learned. So as Ryan mentioned, the machines draw significantly more power than our old machines. We were running into a lot of issues where our units were not charging and we didn't understand why. And upon consulting with our electrical department, it was determined that we needed a higher power rating for our outlets, and they were able to designate these for us so that they have designated charging stations. We have 2 units at our main site, and only one of these units has a 24/30 detector, which has to be shared between either of the machines. It can be detached and reattached to each unit. The important thing to note about this is that it's very important to ensure that you have the correct imaging receptor and detector selected prior to your exposure. Otherwise, the machine will still expose, but you will end up with no image. So that's part of a workflow that we will suggest for later. Your Wi-Fi can fail. So even though our hospital network has a very strong Wi-Fi signal throughout the entire hospital, every now and then it does, of course, fail. So you want to always be checking that you are connected to the Wi-Fi network and that your work lists are generating new information. If you have an issue with sending images to PACS, then you need to connect to a wired port so that the images will send and your work list will update. So even though we can operate faster, we should still have patience. So a very common statement that people have made is that, oh, it's easy to make a repeat. But that's obviously the mindset that we want to avoid. So we can operate the machine faster, we can get the image faster, so that allows you to take the extra bit of time to make sure that you've set up your patient properly, you've checked to make sure you've maintained a proper exposure technical factor, and that you've set everything up so that you don't have to do a repeat. So the machine is smart, it detects bumps, and these can be from driving into an elevator too fast. The detectors are extremely expensive to replace. The 35x43 is roughly around $50,000 to replace, and given that we only have one for each machine, it puts down one machine completely if the detector is needing service. So the solution is always ensure that the detector is placed in a safe spot. You're not setting it on the floor. You're not allowing nursing staff to remove it from behind the patient without instructing that it's extremely heavy and tricky to move and should not be set down without special care. So we make sure that the X-ray techs are the only people that hold on to the detector, and they are put back in the machine or at a very safe spot on the floor so that it can't be stepped on or broken. And like I say, encourage staff to take their time when taking an image. So very quickly, a suggested workflow. You need to sign into the machine, check your battery status and Wi-Fi status. There's a battery status for the overall unit, but each detector has a battery as well that can be easily replaced and charged right within the base unit. Select your patient and ensure that you have the correct IR selected, so prior to actually placing it behind the patient. Confirm your patient ID. Again, this is shown right on the information on the screen, so you can check their date of birth and any other identifiers. Check for previous. Any previous done on the same unit will appear so that you can check exposure and technique so that you have something to set for your current patient. Adjust your technical factors accordingly. Place a detector, set up your tube, expose the patient, remove the detector, and send the image. The most important step, confirm that if you have changed your IR, if you changed it to the smaller the 25 by 30, change it back to the usually used 35 by 43 so that the next technologist won't have to worry about changing their IR first, and then lastly, return to your department. So overall staff feedback is overwhelmingly positive, coming from technologists, nurses, and doctors. Everyone loves that they can see the image right away, that it has a feature that easily allows you to visualize lines without having to go into PACS and window the image. We have a better range of motion in comparison to other digital units and the previously used Siemens mobilettes within our department. The detector weight is actually similar in comparison to other digital units, information that has been provided to us by technologists that work at other sites and use other digital mobile detectors. The machine is lightweight to drive and should be pushed, or could be pushed single-handedly should you choose to. So 2 very quick case examples. X-ray was called STAT to the NICU to a newborn in respiratory distress. The post-intubation image acquired demonstrated that the ET tube was not, it was advanced too far and that there was a whiteout lung. The detector was, the doctor reviewed the image immediately, advised for a change in tube position, and then a recheck of the image. So since everything was already set up, we didn't need to move the baby, the detector didn't need to be moved, the technique and technical factors didn't need to be changed. No additional setup was required, and the new image actually demonstrated a fully inflated lung, and that was done within seconds. So this patient care is obviously beneficial for all patients within the hospital. And then furthermore, trauma imaging is extremely easy because of the increased range of motion of the tube head. I'm sure you've all had examples where you struggle to get the detector onto the patient because of an open fracture. Trying to get the angle and match to the detector to make sure that you're not elongating or foreshortening the bone is always an increased challenge. So oftentimes, technologists will actually move the digital machine into our imaging rooms to obtain tricky images so that you don't have to work around the standard equipment within the room. We can use our mobile images or our mobile unit to help obtain those images a lot faster and a lot easier. And that's our presentation. Any questions? Are there microphones?